The biomedical model of medicine has been around since well before the 1960s as the predominant model used by physicians in diagnosing diseases. According to the biomedical model, health constitutes the freedom from biological malfunctioning of the human body, aka disease. Thus, the average human condition is healthy. The model's focus on the physical processes, for example, pathology, biochemistry, and physiology of a disease, do not take into account the role of social factors or individual subjectivity. In the late 1970s and early 1980s, medicine, as it is now, was changing rapidly. Dr. George Liebman Engel, an American internist and psychiatrist at the University of Rochester, wrote a seminal work describing the need for the biomedical model of medicine to change to the biopsychosocial model. Dr. Engels posited that while the biomedical model is excellent for describing certain disease mechanisms, for example viral illnesses, it has difficulty accounting for psychological and sociological factors that influence most, if not all, illnesses. However, he only mentions spiritual factors in terms of pre-scientific medicine and spirituality being used to explain psychological processes at that time. He does not acknowledge the positive or negative impact of spirituality on a patient's well-being, quality, and longevity of life. Thankfully, over the last few decades, there is overwhelming support for addressing the biopsychosocial needs of patients, as that has led to better outcomes. But there is also ample evidence to address the spiritual needs of patients. Dr. Harold G. Koenig is a psychiatrist on the faculty of Duke University. He has published over 280 scientific articles in peer-reviewed journals and 60 chapters in professional books. Throughout his career, he has helped establish some of the main tenets regarding why addressing spirituality in medicine is necessary. These reasons are as follows. 1. Spiritual beliefs are common among patients and serve a distinct purpose. 2. Spiritual beliefs influence medical decision-making. 3. There is a relationship between faith and health. 4. Many patients would like their doctors to address issues of faith and health. 5. Addressing spiritual beliefs with patients often improves the doctor-patient relationship. Due to an exuberance of data regarding the benefits of addressing spirituality in healthcare, the AAMC has added to their guidelines for creating medical school objectives in their most recent update. They state, in order to communicate effectively with patients, physicians will also need to understand how a person's spirituality and culture affect how they perceive health and illness, and particularly their desires regarding end-of-life care. This notion has also translated to the accrediting body for hospitals called the Joint Commission, whose most recent standards state that a spiritual assessment should, at minimum, identify and accommodate a patient's cultural, religious, spiritual beliefs or practices that influence care in every aspect from food to medicines to end of life. This assessment involves determining the patient's denomination and beliefs, as well as what spiritual practices are important to the patient. Finally, the American Psychiatric Association has also recommended that physicians ask about the spiritual orientation of patients so that they may properly attend to them in the course of treatment. Briefly, before going any further, according to the Oxford Dictionary, spirituality originates from the Latin word spiritus, which means breath. And like breath, the spirit is regarded as a fundamental part of being alive. It is defined as the non-physical part of a person, which is the seat of emotions and character, the soul, the thing regarded as their true self and is capable of surviving physical death or separation. Thus, spirituality is anything that pertains to the non-physical part of a person. Despite these definitions, there are some misconceived notions regarding spirituality. Namely, there is a common misconception that spirituality equates to religion. However, it is much more than that. For example, religion focuses on organized beliefs, solitary and social practices, while spirituality encompasses those things, as well as other aspects of interacting with one's higher power, like prayer, meditation, and a relationship. Another common misconception is that spirituality equates to faith. However, spirituality only overlaps with faith in some regards. For example, one can have faith in physical objects, such as faith that a medication will help lower blood sugar, while spirituality deals with anything non-physical. Another example is faith that prayer will help lower one's blood pressure, while continuing to take medications. This second example shows how spirituality can work in terms of faith, specifically faith and a spiritual effect on the body, while maintaining continued faith in the physical medications affecting the body. Dr. David Holmes, a family medicine physician and director of global health education at the Jacobs School of Medicine and Biomedical Sciences, demonstrated the concept in this way. Within the sphere of religion are the acts and practices of a spiritual nature, while faith is a belief in or about the physical and non-physical world, while spirituality is anything pertaining to the non-physical world. Within this definition, I will discuss how the biopsychosocial spiritual model interacts with a patient's healthcare. From a biological perspective, it is often very clear how patients may be affected by diseases. For example, hepatitis C, although unseen on a shared needle, will chronically infect 60 to 80% of individuals using those needles. Over a 3 to 12 week period, these individuals will be asymptomatic until the virus has begun, causing them to have weakness, malaise, anorexia, and other nonspecific flu-like symptoms. Ultimately, this virus culminates in liver decompensation and death at a variable rate if not addressed with antiviral medications. Nutrition is another very crucial component of health within the biological sphere of the biopsychosocial model. For example, a diet in excess of recommended caloric intake has been shown to cause type 2 diabetes through insulin resistance and elevated blood fatty acid levels, leading to cardiac disease and premature death. However, nutrition can also have very positive health outcomes. Beyond disease prevention, it has been shown to increase longevity of life and mood. One way that altering nutrition is able to increase longevity of life and mood was explained at length in a review article published in the New England Journal of Medicine. The authors describe how overweight, young, and middle-aged adults who fast for 16 hours twice a week can have broad-spectrum benefits for many conditions such as obesity, diabetes mellitus, cardiovascular disease, cancers, and even neurologic disorders. Exercise also has a deep link within the biological sphere of the model. Not only does increased daily exercise prove to be effective in lowering BMI and the risk of heart disease, but it is even effective in treating other seemingly unrelated diseases. In a case report in the International Journal of Rehabilitation Research, a 48-year-old male with a diagnosis of Wernicke-Korsakoff syndrome, confirmed with MRI, was treated with detox, intramuscular thiamine, 8 weeks of intensive physical rehabilitation, and had improved his mini mental status exam score from 10 out of 30 to 20 out of 30. Thus, the combination of exercise and nutrition significantly improved his cognitive functioning, the biology of his brain, and quality of life. Vaccines are biochemical tools used to prevent disease in the individual and society, providing longevity and improved quality of life. This has been demonstrated by the mortality of diphtheria, polio, measles, rubella, and smallpox declining by greater than 99% since the institution of vaccines. However, simply having access to these vaccines does not make them accepted by all patient populations. Therefore, good education, an abundance of respect, empathy, and evidence while taking into consideration the whole person being treated are necessary for interventions like these to be efficacious via adherence. As I begin to discuss how psychological factors are innately tied to health, I will attempt to synthesize how a patient's psychology affects their biology and vice versa. First, there are many major components of a patient's psychology that affect their health outcomes. From a multinational review that sifted through 15,000 research papers and found 20 relevant studies of the various psychological components that affect patient health outcomes through physical activity, the authors found that emotions, perceptions, motivations, goals, personality, values, intelligence, and understanding of the benefits of activity all had positive effects on patient physical activity, while the presence of psychological disorders like depression had a negative effect. Another example of the psychological state of an individual affecting outcomes is well known in the population of patients diagnosed with chronic liver disease, as there is a larger burden of depression than that of the general population. In fact, the mortality of patients diagnosed with chronic liver disease is not only due to irreversible cirrhosis, but also complications like hepatocellular carcinoma and mental diseases, especially depression. In a study from 2015 by the Liver International Journal, the authors demonstrated that patients without liver disease and suffering from major depression attempted suicide 13% of the time, while those with liver disease attempted suicide 33% of the time. Multiple studies have found that patients with viral hepatitis C have a higher prevalence of depression, but there is also an association with individuals receiving interferon alpha treatment for the disease. Studies that investigated the link between interferon alpha treatment and depression found that ethnicity modulates the genetic risk for depression with therapy, and that polymorphisms in the promoter region of interferon alpha beta receptor 1 can increase the risk of developing depression in hepatitis C patients who are receiving antiviral treatments. Thus, multiple studies have concluded that treatment of comorbid diseases are the most likely to result in therapy success, as many patients with depression can become non-compliant or succumb to the thoughts of suicide. Interestingly, in an animal model of reduced dopamine-producing gut microbes, the process of cirrhosis was accelerated, and ongoing research is looking at the link between neuropsychiatric dopamine processes like depression and acceleration of physical diseases like cirrhosis. Finally, from a psychological perspective, physicians can help provide education to mitigate the possibility of poor outcomes from things like not understanding the need to take medications for type 2 diabetes because of a lack of a feeling of their effect. Socially, patient health is directly affected by their socioeconomic status, as that influences medication affordability, access to healthcare services in geographic locations, access to healthy foods, access to safe exercising locations, access to lead-free or allergen and pollution-free living conditions, access to low-violence environments, access to appropriate working conditions, and many, many other things. Other social factors include insurance status, as there are many studies that estimate that people without insurance die quicker. The inability to work is also a social predictor of death. Family and friend influences can also have effects on a patient's health, like betel chewing, and social circumstances and likelihood of cirrhosis. Furthermore, decades of studies demonstrate that people who join support groups for their respective diseases or struggles have better health outcomes, and those who volunteer and help others have better outcomes than those who do not. These examples don't even demonstrate the impact that one's culture can have, both in negative and positive ways, on a patient's health. However, culture must be a component of whole-person healthcare for the best outcomes in medicine to be achieved. Spirituality is a necessary component of the whole-person healthcare model. This is in large part due to spiritual behaviors having positive effects on a patient's coping mechanisms via prayer and meditation. Additionally, spirituality has positive effects on a patient's social life and psychological circumstances through religious service attendance. Importantly, some medical decisions are often influenced by a patient's religious affiliation. For example, Jehovah's Witnesses cannot accept whole blood, and pork derivatives are not acceptable for Muslim populations. Furthermore, a large body of research has now emerged suggesting that religious participation is strongly associated with numerous positive health and well-being outcomes. Longitudinal studies that control for confounding variables indicate that religious service attendance is associated with greater longevity, less depression, less suicide, better cancer and cardiovascular survival, less divorce, greater likelihood of making new friends and social support, greater life satisfaction, greater meaning and purpose in life, more charitable giving, and greater civic involvement. While many of the earlier studies were methodologically weak, there are now, for the outcomes and references listed above, rigorous studies with longitudinal designs, large sample sizes, and extensive confounding control, including control for baseline outcomes, suggesting associations of fairly substantial magnitude. Knowing that spirituality can have such a significant effect on a patient's health is important because we have developed tools for assessing current spiritual behaviors and thus determining areas that could be improved and positively affect health. One such tool is taking a spiritual history with the mnemonic HOPE, developed by Brown University School of Medicine. H stands for hope, meaning comfort, strength, peace, love, and connection. One way of asking this is, we have been discussing your support systems. I was wondering, do you have any religious or spiritual beliefs that act as a source of comfort and strength in dealing with life's ups and downs? O stands for organized religion. One way to ask about this is, are you part of an organization such as a temple, mosque, synagogue, church, etc.? And I think the most important question to sneak into this is, how important is this to you? P stands for personal spirituality and practices. One way to ask this is, do you have personal spiritual beliefs that are independent of organized religion? Like, do you believe that you gather strength from nature, society, or a sense of balance? And this question can be tailored based on prior answers. If they state that they do have an organized religion, ask, what kind of relationship do you have with God? And what aspects of your spirituality or spiritual practices do you find most helpful to you personally, like meditation, prayer, reading scripture, attending religious services, listening to music, hiking, or communing with nature? E stands for effects on medical care and end-of-life issues. This can be asked in this way. As a doctor, is there any way that I can help you to access the resources that usually help you? And are you worried about any conflicts between your beliefs and your medical situation, cares, or decisions? By taking inventory of a patient's spirituality, you can also identify potential interactions with your healthcare management strategies. For example, the patient's beliefs and practices may be contradictory or uphold evidence-based medicine. And by obtaining a spiritual inventory, one can gain the appropriate insight into how to address these beliefs effectively. Often, doing a comprehensive physical exam in history is not possible. Thus, there must be some discussion of when these types of interventions are best implemented. First, in inpatient and outpatient settings. The order of operations is to establish as follows. You take care of medical needs before all else. A patient with a broken arm may want prayer and the ability to push through rosary beads or open the Bible, but first you must fix the arm. Then taking care of the psychosocial needs takes precedent. A patient who does not trust, is delusional, is in a current episode of psychosis, cannot currently discuss their higher level needs. Thus, it is important to address those first. Finally, addressing the socio-spiritual needs of hospitalized patients requires forming trust and sympathy with the patient, providing a desirable environment, appropriate communication from the medical team with the patient, and respecting the patient's dignity and beliefs. Of note, addressing spiritual needs can always be done during a general physical, work physical, or sports physical. Another scenario where the biopsychosocial spiritual needs must be addressed is in terms of addiction, as it has been shown that the most effective methods for treatment of addiction are those with appropriate medication, counseling, support in groups that believe or rely on a higher power. The last scenario I want to mention is one of the most paramount for physicians to address spirituality, and one of the most difficult, and that is during end-of-life care. For a thorough analysis, I'll walk through a case report. A 43-year-old pregnant woman with a history of prior C-section, T-shaped uterus, hypothyroidism, fibromyalgia, and depression was found to be giving birth to a boy with Patau syndrome, aka trisomy 13, and suspicion for placenta accreta. Due to the complicated nature of the baby's presentation, a birth plan discussion including the baby's poor chance of survival, the difficulty of the mother's surgery, and how the family wished to deal with having a healthy or dying baby took place. The obstetric department took a team approach, involving a palliative care physician, nurse practitioner, social worker, and genetic counselor, in order to understand the family's anticipatory grief. At birth, the baby was healthy enough to be handed to the father in a special blanket made by the mother, while mom received a hysterectomy. In a short period of time, the baby became weak and with little respiratory effort. He was immediately baptized and blessed by the priest in the delivery room. While attempting to stimulate the baby and provide skin contact with mom, she needed to undergo additional anesthesia for the hysterectomy. Accompanied by staff, the father brought the baby to eager siblings. Shortly thereafter, the mother's surgery was ending, and instead of a normal protocol of post-anesthesia unit, the mother was brought to the room with the family and the appropriate staff for her monitoring. Due to the physician's commitment to reuniting her with the baby, she was able to hold him while he died peacefully, and then perform rituals they had previously identified to be important for their closure, including a teardrop card outside the door for staff to be respectful of the circumstances, and molds, pictures, keepsakes, and a memory box. After their son's funeral, they wrote the team, "Thank you for the support and prayers during our stay. The difficult time was made easier due to your efforts." In conclusion, when taking care of patients, it is imperative that we as physicians attempt to provide care that will most effectively impact our patients' health and well-being. This involves addressing, in a patient-centered approach, the physical, mental, social, and spiritual components of their being. Of note, praying for patients who ask for it has been shown to have tremendous benefits for patient-doctor relationships, which in many cases can be the crux of therapeutic efficacy through alliance, and also makes the care of terminally ill less frustrating and more fulfilling. The bottom line is that in order to accomplish highest quality patient-centered care, one must A. Take a biopsychosocial spiritual history. B. Address any of those issues as needed. C. Utilize patient sources of strength and support as tools to help patients to optimize their health and well-being. D. Consider praying with patients if there are indications to do so as per Dr. Koenig's book. And E. If indicated, consider referring patients to clergy, social, spiritual support groups, or counselors, just as we refer to other medical specialties.